Robin Severy, who's a physical therapist in the Valley, will act as my model patient today. We're going to go over the physical exam next. And my physical exam actually starts while I'm interviewing the patient or getting the history. And what I'm observing as I'm in front of the patient, looking at the patient, is that the overall posture, the definition of the deltoid muscles, the position of the neck. I'm looking for any prominences, especially at the sternoclavicular or the acromioclavicular joints. And I'm looking at muscle development to see if it's symmetrical. And overall, I'm just looking to see if the patient is comfortable. Most of the physical examination of the shoulder is performed standing. And after we've observed the patient from the front, which we were doing while we were obtaining a history, we have the patient stand. And by examining the patient from the back, I can really look at symmetry of the shoulder, the position of the neck. The neck should have a little bit of lordosis or backward bend. We also look at the thoracic spine, and individuals that have a forward bend or a kyphosis can also have shoulder problems. We look at the scapula or the shoulder blades to make sure that they're symmetrical. There are some abnormalities, some congenital, known as Springle's deformity, where you can have a scapula which is descended compared to the contralateral side. That can affect biomechanics and kinematics of the shoulder. The other thing that we look for is winging, any static winging of the scapula, and we're able to do that by looking at the inside border of the scapula. Another important thing that we're able to look at is any atrophy of the muscles. The supraspinatus fossa, where one of the main rotator cuff lives, the infraspinatus fossa, and the teres minor. What I have the patient do next, after I've observed, is I have them do active range of motion and abduction. So I have them put their arms out to the side and go all the way up. And what I'm looking for, one, is if there's a painful arc of motion, and I'm looking at full range of motion. And the nice thing about the shoulder or upper extremities is that we have two of them, so we could always compare to the normal side. And then as the patient comes down, what I'm looking at is motion of the scapula. Individuals that have weakness in the scapular stabilizing muscles will have what we refer to as scapular dyskinesis, or abnormal or asymmetrical motion of the scapula. And many times, patients that have shoulder pain, if we just address that weakness, they will improve. So once we've done abduction, we check forward flexion, going straight out in front. And again, we're looking at total range of motion compared to the contralateral or other side. We're looking for any discomfort. We're looking at the arc of motion. And again, we're looking at the scapula. The other range of motion I'm able to check from back here is internal rotation. And one nice way to check this is to have the patient scratch their back and have them go up as far as they can. And most of the time, the patient will be able to get into the mid-scapular plane, which Robin is able to do. And this is approximately the fourth thoracic level. And this is how we measure it. In the normal shoulder, we'll measure it, and then we'll measure it in the painful shoulder. And we're able to tell a difference, and we do it by thoracic levels. Robin's is normal, so she has good range of motion. Also from the back, I'm able to check range of motion with the arm abducted at 90 degrees. And this is probably a little bit better measure, and I'm able to check external rotation and check internal rotation. And again, we're able to compare that to the normal side. I have the patient then turn to the side, and after I've examined the patient from the back, I turn to the side and we do the palpation part of the examination. And the first part that we palpate is the collarbone. And we start at the sternoclavicular joint, palpate along the collarbone, all the way to what we call the acromioclavicular joint. And again, this is the joint that is commonly separated with a fall directly on the shoulder, or patients can develop inflammation of this joint just from repetitive use. And if they have pain here, they should have pain to direct palpation. Now, one of the processes of the scapular shoulder blade is the coracoid process. And you can easily palpate that just inferior to the AC joint. And people that have that scapular asymmetry will often have pain right over the coracoid process because one of the pectoral muscles attaches there, and it can be very tight or contracted and be painful over the coracoid. Now if we palpate just lateral to the coracoid, I can palpate the bicipital groove, and that's the groove that the biceps tendon runs in. And this is often painful in individuals that have inflammation or biceps tendonitis. Then by just easily, passively rotating, by externally rotating it with my finger on the bicipital groove, I'm able to palpate the subscapularis, or the big fleshy rotator cuff muscle in front. Then by internally rotating, I can palpate the supraspinatus, because I can feel what's called the greater tuberosity, which is part of the humerus bone where the supraspinatus attaches. I can also extend the shoulder, and this also brings the supraspinatus into the area that I'm palpating. In patients that have a tear or inflammation of the rotator cuff will often have pain here. We then palpate around the side of the acromion, again over the supraspinatus, and further back we palpate the infraspinatus, or one of the posterior rotator cuff muscles. By forward flexing and adducting the arm, we can bring that infraspinatus and then the teres minor closer to the field, and we can more easily palpate this. We also palpate along the scapular spine. We can palpate the supraspinatus fossa, infraspinatus fossa, and then we just palpate around the scapula looking for any trigger points. After we finished our palpation, then we go into some tests to look for rotator cuff injury or also injury to the acromioclavicular joint. And again, with me being at the side, I passively bring the shoulder up above the head. And once patients get to about 90 degrees, if they have inflammation of the rotator cuff, this will become painful. And to make this test a little bit more sensitive, we can internally rotate the arm and bring it up, as this brings the rotator cuff more underneath the acromion, and that's called the Hawkins test, and that's positive for rotator cuff irritation. While I have the arm here, I passively bring the arm across the chest, and this is called a cross-arm adduction test. And what we're looking for here is inflammation at the acromioclavicular joint. Patients, if they have an acute injury or if they're weightlifters, do a lot of labor activity and have inflammation, will often have pain with that activity. Another test that can be done is called the O'Brien test. With the arm across the body gently and the thumb facing down, I have the patient resist me and I push down. And pain with this maneuver can be caused from the AC joint, or if the patient states that the pain is deep in the shoulder, then it's more likely due to a labral or ligament injury in the shoulder joint itself. Similar to the O'Brien test, if we bring the arm out, we do what's called the Jobe supraspinatus test. This test will isolate the supraspinatus tendon of the rotator cuff, which is the one that's most commonly involved with inflammation or tears. And again, with the thumb down, I have the patient resist me. And weakness and or pain with this maneuver is suggestive of rotator cuff problems. While I still have the arm, I passively put the arm through a range of motion, trying to feel for any painful pops. Robin has a pop, but it's probably not painful. And by compressing the elbow in toward the body, if individuals have what we call a slap tear, that's the labrum where the biceps attaches, or just a labral tear, we'll often get a painful click in the shoulder. In this position, I'm also able to passively abduct and externally rotate the shoulder. And individuals that have anterior instability will often develop apprehension with this maneuver, and they will resist this maneuver.